All right, happy Friday to everyone. Welcome to another Friday of the AMSSM Sports Ultrasound case series. We had a short break after the fellow session this spring and early summer, and we're getting started over the next several months with our staff session. So today, to kick that off, is Dr. Ike Hasley. Dr. Hasley attended St. Louis University for his undergraduate education before returning to University of Iowa for medical school. He did his physical medicine and rehabilitation residency at Mayo Clinic in Rochester, and then a sports medicine fellowship at Mayo Clinic Square in Minneapolis. He is going to be starting a position at Summit Orthopedics in the Twin Cities here in Minnesota in September. Dr. Hasley is going to be presenting on Flexor Carpi Radialis Tendinopathy. All right, go ahead, Ike.
All right, thank you, Dr. Betcher. I'm going to share my screen here. Are you guys able to see this?
Yeah, it looks good.
Hear me? Okay, sounds good. Well, like Dr. Betcher mentioned, I'm going to be talking about FCR Tendinopathy. First off, I have a ton of people to thank: Dr. Ellie Jelsing, Dr. Jeff Payne, Dr. Shelby Johnson, all critical during my fellowship here at Mayo Clinic Square. Also all the Mayo ortho and sports medicine surgeons, physical therapists, athletic trainers. Really takes a village, which continues on this page. Dr. Sellen, Dr. Betcher, also critical during my fellowship year. It was Dr. Hall and Dr. Cruz who got me interested in this specialty when I was a med student at Iowa. Dr. Steve Wisniewski, Dr. Britt Moore, they should be on here as well. I also really want to sincerely thank Dr. Betcher and Dr. Cruz for letting me reschedule this. I was supposed to give this in early March, and due to the passing of Dr. Mick Beast, my close friend and ultrasound buddy, he tragically took his life on February 15th. And so they were very gracious in letting me reschedule this. And just my mental health plug is, make sure you're taking care of yourself and your colleagues and friends. So with that being said, thanks again. We're going to today review the scanning protocol for the ultrasound eval of the volar wrist. We're going to identify normal and pathologic ultrasound findings, review relevant anatomy, discuss the pathophysiology of FCR tendinopathy, and compose a diagnostic report. Quick HPI, this is a 62-year-old right-handed gentleman coming to us for left wrist pain. This began 1 month prior while weightlifting. He localized it to the radial aspect of that left volar wrist. It was rated as mild, helped minimally with conservative stuff like rest, ice, NSAIDs, activity modification. It was really worse with biking and that axial loading. So anytime that wrist got forced into extension. Physical exam, in terms of inspection palpation, he had minimal swelling, associated tenderness with palpation of the radial aspect of the volar wrist, right over the FCR tendon, essentially. Otherwise non-tender. Range of motion, he had pain with terminal wrist extension. This was worse with axial loading. Otherwise, essentially normal. Strength was, he did have pain with resisted wrist flexion. Again, otherwise normal. Neuro, intact. Provocative maneuvers, especially those carpal tunnel compression ones, essentially unremarkable. So scanning protocol for the volar wrist that we're going to be focusing on today. We're going to go over the carpal tunnel contents, some tendons. We're going to look at the ulnar nerve and artery, and then kind of these joints as clinically indicated those are the instructions we're giving. We're also, depending on the clinical question, there's these other structures on the right side of the screen here that we can look at. We're not going to look at every one of these, but some of them are relevant, so we'll take a look at a few of them. In terms of ultrasound consideration, one, can we answer the clinical question? I think for the hand and wrist, ultrasound is a really great modality. But if this is just a bony or joint question, then obviously we want to look at that with X-rays. So one, can we answer that question? In terms of transducer type, I've got a few. I do think this should be linear. I haven't really seen anyone use a curvilinear in the hand or wrist area. I listed this mid-frequency here on the right as especially a carpal tunnel eval. If someone's got big meaty hands, it's just hard for those high frequency transducers to penetrate and eval that. So I really like the mid frequency for it's usually males that have those really large meaty hands, and so that can be super helpful. Otherwise, we're using a high linear, even a hockey stick when indicated. Patient position might depend on your office or clinic setup. Most likely semi-recumbent if you're in a procedure room. They can be sitting. Sometimes we've got those hand tables where the patient can just essentially face you, the provider. Because we're on the volar wrist, likely going to be supinated. So just making sure that they have the range of motion capabilities for that. So diving into our ultrasound eval here, we're going to start with the carpal tunnel contents. These have been pounded in a lot of people's head by now, but if you're not sure, there's 9 tendons in the carpal tunnel. The FPL, there's 4 FDS, 4 FDP, and then a median nerve as well. So we're starting here at the inlet. The blue outline here is indicated. There's a little map up here that I'll use throughout this talk, and that's going to orient the viewer as to where we're at. So blue here, we're right at that wrist crease. We know that we're at the carpal tunnel inlet because radially we have the scaphoid here. Ulnarly we have the pisiform. These should be nice and round. As we translate distally, as indicated by our color schema here, those are going to fall off and they're going to be replaced with the distal carpal bones. And so this is going to be the hamate on the ulnar side and the trapezium on the radial side. And so we start off with these rounded cortices, and they eventually get replaced by more pointy cortices. And some people describe those as shark fins. So that's kind of the proximal and distal aspects of that carpal tunnel. We also see the TCL really nicely here, the transverse carpal ligament or flexor retinaculum as well. And we're also just orienting ourselves here. You know, this is a mid-frequency. We can see a lot of stuff. We're going to have our FCR over here, which we'll look at better in a little bit. Our FCU is going to be sitting right over here. So really just taking some broad sweeps at first and getting a lay of the land. While we're on this carpal tunnel area, we can also have the patient just start moving around. They can move their fingers. We want to see that the median nerve is moving around nicely. It's not getting trapped or anything like that. The fact that it's mobile means that, you know, that can provide us some clue as to whether there may be some median neuropathy or carpal tunnel syndrome going on or not. This person had a nice mobile median nerve. We see the tendons moving around as well. We can have them flex and extend their wrist to bring the lumbricals or the flexors into or out of view. Going back to that flexor retinaculum or transverse carpal ligament. So this starts over on the scaphoid and will go across over the carpal tunnel contents, and will come down to come ulnarly to insert on the pisiform, and it essentially forms the floor of Guyon's canal, which houses the ulnar nerve and artery, which we'll be looking at as well. We just want to look for the general appearance of this. Sometimes these can be really thick. As with most things, we're going to turn on this 90 degrees, which is just a motion that any new or advanced ultrasonographer should really get good at. So we're going to keep this in the middle of our screen, turn on it, and we can start coming distally to find the distal aspect of that. Here we see it tapering off. Some people describe it as like a shrimp head with the antenna continuing out over towards the superficial palmar arch. Also, one thing to keep in mind that I forgot to mention, while we're doing that, we want to be right over that median nerve. That basically just shows us that, or that proves to ourselves that we're in the right spot while evaluating this. Going back to our median nerve, we're going to measure this at the level of the pronator quadratus. It doesn't really matter where. And so right here, we measure this. It's right in between the FDS and the FDP. And we've got that at 8 millimeters square. Then we measure it at the level of the carpal tunnel inlet or the wrist crease. And so this person's median nerve is a little bit large. 10 is known as the kind of the upper limit of normal. I would say this is borderline, but given the fact that we've got greater than 2 millimeters of increase, this could be consistent with carpal tunnel syndrome if the patient was experiencing those sort of symptoms. This person was really not, and our physical exam was pointing away from that, but just something to note on our exam. In terms of looking at the nerve in long axis or in more of a sagittal view. So again, we're going to spin on that. We're going to we've got distal to the left here, proximal to the right. We're going to look at the way that this nerve is going under the transverse carpal ligament into the tunnel. Is it getting pinched off and tapered down here a little bit? Possibly. I think you'd have to really evaluate this a little bit more. It'd be hard to make that call just on one image, but we just want to see what this nerve looks like in long axis as well. So next on our list is the Flexor Palmaris Longus tendon. I like to come up and find this proximally. So we're superior or proximal to the wrist crease. And I basically just like to have the patient wiggle their thumb, and you can do this as well. That really brings out this muscle belly nicely, and I think it serves as a good landmark. We've got AIN down here. You can see our radial artery over top. If you're an EMGer, you know that FPL is right next to that radial artery, and that's how we find that with EMG. We can see our median nerve in here. I think this is just a really good way to orient yourself. We're going to follow this distally, and we're going to follow it down. So here it is in the middle of our image here, and we're following it into the sesamoid bones of the thumb here. So these are those sesamoids that should be right on top of that. Again, we're just making sure that we can follow that distally. All of these things in the wrist and forearm, you can trace as proximal or distal as kind of indicated, or, depending on your clinical suspicion. In this case, the patient did have pain right in that area. So I think it's appropriate to do a thorough assessment of the FPL and make sure that their strength is intact on physical exam as well. Here we're seeing that FPL in long axis now, distal to the left, proximal to the right. It's inserting onto that distal phalanx, and so that's what's going to flex that thumb. We can also do some dynamic images and videos just to make sure that there's good movement. We're not seeing any separation of those fibers, and that everything is intact. So this looked good. As with most other things so far, aside from some mild enlargement in that median nerve. Looking at the FDP and the FDS, this has a unique insertion pattern or movement, if you will, that's a little bit out of the scope of this volar wrist exam. As we know, the FDS will actually split around the FDP as it inserts onto the fingers. My video is being a little bit stubborn here, but essentially we're just following this distally and proximally across the carpal tunnel. So here we're a little bit proximal, and I really like this image right here. We can bring out the FDS and the FDP, and now we're seeing that FDS start to split around the FDP, insert onto the middle phalanx, while the FDP continues towards the distal phalanx. And so depending on your clinical suspicion, this patient didn't have any triggering or anything like that, no pain or weakness with finger flexion. So didn't spend a whole lot of time here. I just really like this kind of video. It gives you a big broad sweep and good lay of the land of what's going on with, at least 3 of their 4 flexor tendons. So again, didn't choose to focus on those in a long axis view, but could certainly be indicated if you're looking more into the hand. Moving to the Palmaris Longus, this is a very small tendon. It sits right over or superficial to the carpal tunnel. Will actually insert onto that transverse carpal ligament. So we've got it here in the middle of the screen. Again, very small, and it's basically just going to blend with that Flexor Retinaculum or TCL. Again, I like this image right here. The Palmaris Longus can have really variable anatomy. It can be congenitally absent in about 10 to 25% of the population. This can be bilateral or unilateral. But also right here, we have the palmar cutaneous branch of the median nerve. Not on our list, but pretty relevant, I think. This is the FCR over here on the radial aspect of this. And so I think taking a look at this nerve, especially if FCR is on our differential, it really sits right there between the Palmaris Longus and the FCR. This branches off about 3 to 5 centimeters proximal to the carpal tunnel. It's not involved with carpal tunnel syndrome, but something that we should at least take a look at because it's in that area. Now kind of getting to the meat and potatoes of the paper with the FCR tendon, or the presentation with the FCR tendon. So we're starting proximally. It looked pretty normal at first, but as we're moving distally, it's getting very large, very hypoechoic. There's almost this disruption of architecture that we can see. And the scanner right now is trying to trace this down into the insertion of the metacarpal. And we see a little bit of that at the end there, but we're trying to make sure that there's fibers going down to the metacarpal where it inserts. This is a tricky little maneuver that we're going to spend some time on, but right away our radar is up in that this is certainly an abnormal tendon. Very thick, a lot of hypoechogenicity. So we're going to hone in on this. We're going to put Doppler on it. A lot of hyperemia as well. So this is a short axis view, again, axial view, and then we're turning on this to see it dive past that scaphoid. It's going to drop a couple of fibers off onto this scaphoid right here. We know this is the scaphoid because it's a little peanut shape or kidney bean shape, as people have described. It's going to drop off some fibers. It's also going to drop some fibers on the tubercle of the trapezium, which we'll see in a little bit, and then drop most of its fibers onto that second and third metacarpal. So this is, again, the area that we're honing in on, consistent with our exam, pathologic clearly. We're mixing up orientation here. So on this picture on the left, we've got distal to the right. Again, very thick hypoechoic tendon. Here's our scaphoid, and here's the trapezium. This is a difficult maneuver. It's a little tricky, and I struggled with it at first, certainly, and we're going to go over how to really view this tendon, but clearly abnormal here. We do see fibers traversing all the way across. So at this point, we're calling this at least a partial intrasubstance tear, and we're really trying to prove to ourselves that it's not a full tear. One of the things that's really beneficial about ultrasound, unlike MRI, is you can quickly and very affordably just take a look at the contralateral side. So a lot of the papers that I was reading up on FCR tendinopathy recommend doing so. So this is the left here, very thick. The right is also thick and abnormal and hypoechoic, but clearly not as much. You know, this might be, I wouldn't call it twice the size, but it might be getting close. So this is, I think, really valuable with ultrasound. Dr. Smith, Dr. Luong, and Dr. Bianchi described how to look at this. The big thing that we're doing here is we're doing a heel toe or a tilt, depending on if you're sagittal or axial. And the point is to get that beam heading superiorly towards the patient's head, because that tendon is diving deep. And so we need to get parallel to that. So whether it's a heel toe in sagittal or a tilt in axial view, you really have to point that beam superiorly. The other tricky thing about this is it's not just that maneuver, but as we know, we need to get our ultrasound transducer parallel to the bone underneath whatever we're looking at. And so because of the intimate relationship with the FCR tendon and the tubercle of the trapezium, it's off to the side. It's a little bit diagonal, so pointing this way. So we have to get the beam pointing that way as well. So the beam is going to head superiorly and laterally. We also, if you can see, the tubercle of trapezium can almost cover that tendon up. So that's why we can't go straight up and down or perpendicular to this tendon. This is a more normal or healthy example of that FCR tendon. This is the scaphoid radius, and you see it really dives down. Other ways to cheat with this, this is from Dr. Smith's paper. Other ways to cheat that they recommend, just have the patient flex their wrist up, and that will basically bring that tendon more perpendicular to your transducer. This is a good view here on the right in the yellow. This is scaphoid, tubercle of the trapezium, and then the second or third metacarpal. And so again, we're really proving to ourselves that those fibers are inserted all the way and that this isn't a complete disruption. Moving on to the ulnar aspect of the exam, not as high yield, especially in this patient. This isn't where their symptoms were at, but something that we need to check quick. So we're at the ulnar nerve in Guyon's canal. Here's the floor, which is the transverse carpal ligament. And then we're just translating distally to this. And so we're starting to see that ulnar nerve split into two different components. Not spending a ton of time here, but this is a really nice view, I think. We also see our FCU tendon here. This is just a depiction of that. Most of this is going to insert onto the piezoform. And then there's the hamate is also involved. So there's a piezohamate ligament that it kind of blends into. Similar kind of pattern as the FCR, but again, not going to focus on a ton of time here, just due to the nature of the patient's presentation. Going back to the radial side, while we're over that FCR, so this is the FCR over top here. Proximal is to the right. This is the distal radius. And we're also looking at our scaphoid. I think it's appropriate in this case, especially patient had pain right there. Scaphoid is kind of a do not miss fracture. We don't have a trauma history, but I think we should check it here. So we're just taking a look at our scaphoid here, a little bit of a different view. We also see the FPL coming across here and they almost intersect. So an intersection syndrome that I'm aware of doesn't occur as much here as much as the dorsal side, but just something to be aware of. And this anatomy will kind of, it'll basically explain that. We've got FPL moving out radially to get to the thumb and kind of heading over the FCR. I might have flipped them previously when I was describing those. So FCR tendinopathy, it's overlooked pathology due to non-specific clinical symptoms. It's associated with underlying STT complex osteoarthritis. I forgot to mention that while we were taking a look at that earlier, but we did see some degenerative changes in those bony cortices of the scaphoid and the trapezium, as well as inflammatory or proliferative disorders. So rheumatoid arthritis, PVNS, also kind of getting renamed into tenosynovial giant cell tumor can be associated with this. It can be in the form of tendinopathy, tenosynovitis, synovial sheath cysts, with or without underlying STTOA, or a partial or complete rupture. Imaging is often required for the diagnosis because they're not clinically apparent. Usually they just have tenderness and pain over that radial aspect of the volar wrist. The X-rays can demonstrate underlying bone and joint abnormalities. We did not have X-rays for this patient. Somehow this patient got into Mayo without some plain films. I do think it could have been appropriate. I think they came in and we were trying to get them over and the patient had difficulties getting them from their outside prior evaluation. And by the time we had done everything, it was kind of cat was out of the bag, but definitely want to get X-rays when you're suspicious of this because it can show that underlying OA. And then obviously MRI or ultrasound for soft tissue eval, and we've talked about the pros and cons of those. So in terms of our final report, we need to include the patient, date, referring provider, where this was done, the laterality, clinical indication, do we have any comparisons, and what transducers were used. So all this information is here, kind of stock information, but needs to be included. In terms of the final report, so the proximal FCR tendon was normal, but translating distally to just above the level of the wrist joint, the tendon became significantly thick, hypoechoic, and this continued throughout the remainder of the tendon. There were large anechoic defects within the tendon, consistent with intrasubstance tearing, as we talked about. There was mild hyperemia surrounding the tendon with Doppler imaging. There were cortical irregularities associated with the scaphoid and the trapezium that were adjacent to the FCR tendon, and we did see tendon fibers traversing to its insertion. We briefly looked at the contralateral FCR tendon. This was also mildly thick and hypoechoic, small areas of intrasubstance tearing. The median nerve was hypoechoic and enlarged, measuring 11 millimeters square at the inlet of the carpal tunnel and 8 millimeters square at the level of the pronator quadratus, without evidence of sonographic Canals. The remainder of the exam, pretty much all those structures that we talked about that are included in that volar wrist exam were normal. So in terms of a final impression, we've got advanced tendinopathy of the FCR tendon, multiple areas of significant intrasubstance tearing with associated hyperemia and cortical irregularities. There was associated degenerative changes of the underlying STT joint complex consistent with osteoarthritis. And we can go back and take a look at those if I didn't do a good job of pointing those out earlier. And ultrasound findings compatible with carpal tunnel syndrome. And that's ultrasound findings, not necessarily clinical findings. These are the references that I used and have been really great for my training. I mentioned the Dr. Smith and Luong and Bianchi paper. Really fantastic textbooks for anyone, beginner or advanced in ultrasound, as well as the Complete Anatomy app. Just want to say thank you to everyone for letting me talk. Thanks to everyone I mentioned earlier. Definitely takes a village. Going back, I think if there's one thing that I may do differently in a future clinical encounter, probably spend less time, for the sake of this, we were doing the volar wrist regional scan, but probably spend less time on the ulnar aspect of that, given the patient didn't have a lot of symptoms there. One thing that Dr. Smith and colleagues mentioned in their paper is, if we go just radial to that FCR, the brachial radialis, superficial radial nerve, EPL, basically those first and second dorsal compartments, those sit right there. So if I were to do this again, I think I would absolutely spend more time on those. I know that Malia Kali just did an awesome talk on intersection syndromes there. And so I didn't want to, kind of reinvent the wheel, but clinically, I think I would absolutely spend more time looking in that area versus going over to the ulnar wrist. So happy to take any questions or discussion. And here's my email. Please reach out with any questions in the future.
All right, Ike, thanks so much for presenting today. That was fantastic. It's some really great ultrasound images and some great points you made. I'm going to spend a couple of minutes on maybe a little bit of housekeeping stuff, and then we'll get to some comments on this lecture. So I did want to take a minute to introduce Dr. Stephen Schaaf. He's an assistant professor in both the departments of physical medicine and rehab and orthopedic surgery at Vanderbilt University Medical Center. Dr. Schaaf is going to be taking over this case series kind of progressively through this fall, and then starting in the spring session with the fellows, he'll be leading this up as I transition to some other roles within AMSSM ultrasound. And so I did want to take a second to introduce him and welcome him. Some of you will see, progressively more communication coming from him through this fall, and then in the spring, he'll kind of take over. I want to thank Ryan and Doug, who kind of led me into this last fall as I took over, and appreciate their guidance with that. And I think the three of us will at least continue to stay on as much as we can with attending these and providing any comments and feedback as appropriate. But that will transition to Dr. Schaaf. Dr. Schaaf, welcome. If you want to say anything, you're welcome to. Otherwise, I have a few comments on the presentation.
Yeah, just wanted to say, thank you so much, Brennan. Really looking forward to be, in this position and kind of keep the series going, this year, and hopefully we'll keep it up to the high standards that you guys have already kind of created for this series the last couple of years. And Ike, thank you so much for the presentation today. I think this was a really good presentation to start the year and kind of set the bar for the rest of the presentation. So thank you so much.
Thank you.
Yeah, I agree, Ike. So I have just a couple of thoughts, having, gone through this and seen several of these cases and thought I know what I was doing, and then didn't think I knew what I was doing. And then I learned a little bit more than I thought I knew what I was doing. And then I saw some more that didn't fit that pattern. And so, I think just a couple of, pearls specific to the FCR. One is that, it as opposed to some other, tendons, we always talk about, is it a peritoneum or a tendon sheath or tenosynovium? The FCR, does have a kind of true tendon sheath from starting at the myotendinous junction, extending through the wrist and kind of this fibroosseous sort of tunnel. And then that sheath kind of ends as you get to the trapezium. And so there's a region where you have kind of a true gliding tenosynovium. And that lends itself to, I guess, being susceptible in rheumatoid patients. And so a lot of patients who have rheumatoid arthritis or, kind of rheumatologic conditions, you'll see some really intense tenosynovitis, like clear fluid hyperemia, associated with sometimes structural changes on the tendon, sometimes not. And I think that is kind of one area of this. And I don't think that your patient necessarily represented that. The other group of people that seem to be kind of a little bit different of a beast are the people who are maybe, laborers or something like that, or they have some trauma in the past. And they have these cortical irregularities along the scaphoid or trapezium that are like a mechanical abrasion of sorts to the tendon. And that seemed to be, based on your images, kind of what I saw. And I'd be curious to hear what other people on the talk feel, but my experience has been that when they're associated with kind of these mechanical abrasion sort of findings deep to the tendon, like you were showing, they tend to be a bit harder to treat. When it's purely like a tenosynovitis inflammatory sort of condition, those seem to be a little bit easier to calm down than when there's maybe a mechanical problem. And so just thinking about not just the structure, and you pointed this out, Ike, and it was a great call or a great catch that you noted, but thinking about the things that are around the structure of interest are really, I think, as we get further, along in our understanding of what we're doing and how to treat these problems, really important things to take note of. And so I'm glad you did that. The FCR, just like every other tendon basically in the forearm, is prone to anatomic variations. And I'll say it generally does remain pretty consistent, with that primary second metacarpal insertion, but don't be fooled if you don't see it heading down there. I just had one maybe a month or two ago. You might have been with me in clinic, I can't recall, that the FCR split and part of it inserted onto kind of the palmar fascia, and then part of it headed like radial down towards the second metacarpal, but didn't insert on the second metacarpal. And so, they're not always exactly like we expect them to be. And so just be aware, that if you don't see it there, really pay attention and look and trace those fibers. And then, I always like to think of like, what is the analogous body part or, tendon that you look at, you're like, oh yeah, this looks kind of similar. I always think of this one kind of like the iliopsoas, whereas if you're tracing it like at the level of the acetabulum, it's really easy to see, but then as you want to follow to a lesser trochanter, you really have to like flex the hip, externally rotate, heel toe in. Same thing here is like flexing that wrist or really heel toeing kind of back, proximal to get those distal fibers. I think if we sell ourselves short and only scan to the level of the wrist, we're going to be missing pathology in this tendon. And then I think the last comment I'll make before I see if anyone else has anything is, my personal view, and I think there's definitely some debate on this, is carpal tunnel syndrome is a clinical diagnosis which can be supported by imaging. And so if I was, and this is just a style thing, reporting this, the report of median nerve enlargement, I would say, mild median nerve enlargement at the carpal tunnel is noted. And that way I think if you say the word carpal tunnel syndrome, you're implying that clinical scenario that goes along with imaging or electrodiagnostic findings. And so that's just a little bit of like a nuanced style sort of point, but I think it would be okay to report it either way. That's how I would report that. That's all the comments I have. I know that was a lot, but I don't know if Steve or Shelby, Doug, Ryan, if you guys have anything to add.
Yeah, I mean, I wanted to add a few comments. So Ike, thank you for setting the bar high as we get started with our attendings with this. So sort of entering in a new fellow cycle, there's a lot of good discussion points, some that we have already said multiple times, but I think it's worth discussing. So this is the most common protocol that I do in my practice for a variety of reasons. I know we've talked about this before, but I would not start a wrist exam, or we have a standing protocol or order that you probably want to look at radiographs first, because you're going to see STT osteoarthrosis in this case pretty easily. The other reason, to look at radiographs is you can find pathology on the wrist that you can't see sonographically, but you can only see radiographically. So a very common operation would be in the case of the FCR is a trapeziectomy and tendon into position with basilar thumb arthrosis. And if you're not aware of that and all of a sudden you're scanning, you're going to get confused or wonder what's going on. So again, just to emphasize as we begin the new series, radiographs are very important to look at. My volar wrist protocol starts with the dorsal aspect. And I know I've said this before. And so I get 3 images or 4 images dorsally. And the first one is that of the synovial recesses, both the proximal and distal synovial recesses. And again, already Brennan mentioned an important cause could be inflammatory arthritis. And I think inflammatory arthritis is best revealed dorsally than volarly. And so if you see signs of synovitis, for example, dorsally, it's going to influence how you start to think about what you're seeing volarly with the flexor tendons. For the same respect, I also look at the dorsal scapholunate ligament, because if it's torn and it looks attritional, then maybe you're starting to develop osteoarthrosis in a slack advanced scapholunate collapse pattern, again, which would influence how you think about what you're seeing volarly. And then my final element is that is the DRUJ. The FCR is part of my carpal tunnel protocol. And the reason is I have a collection of cases that were referred for carpal tunnel syndrome that have FCR pathology. I want to also emphasize that the importance of dynamic scanning volarly, because there's a lot of variability. This is one of the areas where we see the most accessory musculature or variability in musculature. And it's going to be hard to interpret if you just start, let's say, at the carpal tunnel inlet. So as Ike, you mentioned, I always scan back and forth, starting in the distal forearm area and scanning through the carpal tunnel to make sure my eye catches any accessory or variable anatomy. And the most common would be an accessory abductor digiti minimi at Guyon's Canal, and then a reverse Palmaris Longus. So in my experience, those would be the 2 most common accessory musculature. If your focus is on the FCR, again, I want to just emphasize what Ike, you said. I think the palmar cutaneous branch of the median nerve is important to look at, but it also has a lot of variability. And so you can have 2, you can have 3 branches of this. It can get very large. I've had a case where we have a PCB neuroma as the cause and not an FCR pathology. I make sure that if I'm thinking about the FCR, I'm also carefully looking at the palmar cutaneous branch. In my practice or my experience, far and away, kind of supporting what Brennan said, scaphotrapezial joint pathology is the most common etiology of FCR pathology. And I've written down here exactly what Brennan said, and it's an abrasive tendinosis. And so given that, I think it's important to understand that if you're injecting the scaphotrapezial joint for osteoarthrosis, you're going to get steroid injectate around a pathologic tendon. So just something to be aware of if you're injecting that joint due to basilar thumb arthrosis is if your FCR is abnormal, you may increase the risk of a rupture. The second most common diagnosis or etiology that I see is calcium position disease. It's a common area to get accumulation there. And what I see oftentimes is just a little bit of synovitis or Doppler activity. So it's not the same intensity as that of an inflammatory arthropathy, but it's not unusual for me to see a small amount of vascularity due to CPPD. Ganglion cysts can often track up the FCR and can mimic fluid within the FCR tendon, and that can be difficult to differentiate. But again, that would be another important etiology of pain at the FCR is a ganglion cyst dissecting its way into the tendon sheath or around the tendon sheath of the FCR. And then probably 4th on my list would be an inflammatory arthropathy. I have not seen pathology at its insertion onto the base of the second, and to a lesser extent, the third metacarpals. It can exist, but it's pretty rare. And then just my final comment is just to say exactly what Brennan said is, we can't really make a diagnosis of carpal tunnel syndrome on ultrasound or imaging. So I would have probably said almost exactly what Brennan said is, I would say mild enlargement of the median nerve within the carpal tunnel, suggestive of, and typically I might say mild carpal tunnel syndrome versus normal variation. You could add, clinical correlation is advised, whatever. So that again is a small point, just reiterating what Brennan said. So anyway, great presentation, a lot of good stuff to talk about, common area that we look at.
Thanks,
Thank
Doug. Anyone else have comments?
Yeah, I would just, this is Steve. So yeah, I would just kind of reiterate, I think for the third time, just as I think you did a really good job just explaining that scanning all the way from the wrist to the insertion for these tendons in the volar wrist, just because as you had mentioned, the pathology isn't always going to be occurring, just at that kind of carpal tunnel area. I think it's just very easy early on as you're doing these scans to kind of just stop. You start to get uncomfortable, when you're going through the hand and then going into the fingers. So just making sure that you're scanning all the way for all these tendons, just because, sometimes the pathology can be occurring a lot more distally. So you're going to be missing out on that. And then as you guys had mentioned, kind of pathology for the FCR. Yeah, the other kind of two unique scenarios that I've seen is for like pediatric patients. I've frequently seen just more tenosynovitis than I have seen, true like tendon tears or tendinosis. And as Brennan had mentioned, usually that's going to be occurring more at the wrist because of that tendon sheath. And then the other additional, very similar kind of along the lines of the osteoarthritis, that I have seen some attritional tears for patients that previously have had wrist fractures and do have hardware in the wrist. So once again, kind of going off Doug's comments, that I think it is always important to have some radiographs at the beginning to kind of know what you're dealing with, especially if they have had prior trauma.
That's a great point about the hardware, Steve. You definitely want to look at that kind of distal volar plate in those folks with FCR and FPL.
Brennan, can I say one thing?
Yeah.
I guess two things. So Ike, obviously great job, beautiful images, great presentation as expected. I think Brennan, you deserve a thank you for the work that you've done with the case series. I think you've maintained the quality throughout all these presentations, and the pearls that you present at the end of the talks have been excellent. So thanks for taking this over. I really appreciate all the hard work that you did. And Steve, we're excited to have you join the team here and take over. And I'm sure things will continue at the level that they've been at. So just thanks, Brennan, and thanks, Steve.
Thanks, guys. All right. Well, I think that ends it for today. That was a great session. So we'll be back in a couple of weeks on August 18th. We have Dr. Sheila Taylor presenting on bicipital radial bursitis. So we'll see you all in 2 weeks. Have a great weekend.
Thank you, everyone.